Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Emily. How are you doing today?
I'm doing well. Thank you for having me.
So, fairly recently, you were at the schoolhouse and you gave a presentation on MDMA therapy. And without turning this into the Joe Rogan podcast, I thought, maybe you should get an actual provider on. So just to start things off, would you mind doing just a real quick introduction of yourself?
Sure. So I'm Emily. I'm a pharmacist by training. I graduated from 2013, and mental health has become more of my passion in the last several years. I actively work within the pain management world as well. So there's a very close connection between pain management and mental health. And I find the bridge to be quite fascinating. And hopefully we are looking for options, I think, in both mental health and pain management chronically within our both civilian, but also veteran and active duty population. So excited to be a part of the hopefully evolving picture of that treatment.
Yeah, sounds perfect. So, just starting off, I've definitely heard of MDMA and what it does. And, essentially, as a street drug is the only time I've ever heard of it. So what exactly are you guys doing over there?
Well, I have to admit, like you said on this disclaimer, it's not necessarily that it is being effectively researched through evidence-based medicine and randomized control trials to evaluate the efficacy for essentially treatment-resistant post-traumatic stress disorder. And we've noticed that over quite some time, some of our more in-the-box traditional use of medications have not been as efficacious as we would have hoped. So we've noticed that for patients that have been on some of our more conventional medications, such as the SSRIs, speaking of things like Prozac and Zoloft are the brand names, but also the SNRIs. So with those, we think about Cymbalta and Effexor. Some of our more conventional medications that have been around for several years have not been nearly as effective as we would have hoped, especially within combat-related PTSD. So I kind of fell into this through a indirect means, working with patients that have found not a lot of help within SSRIs and that class of medication, have kind of told me about their experiences. And then I started researching into it and deciding, well, if I'm going to have clout as a provider or as a practitioner, I need to inform myself so that I can actually have a more educated discussion when this comes up with my patients. And then I became quite fascinated. I really became interested in the true evidence-based medicine of it as well, and decided to take on the training to become an MDMA therapist once it is fully FDA approved, and I can provide that directly to patients.
So, I've never actually gone through this type of therapy, not the NMDA type therapy, but the like SSRIs and more conventional type treatments. But from what I understand, those medications are essentially they sound like they're more on the depression side of things, or to give you a more positive outlook on things. And then that combined with therapy, you work things through. And, unfortunately, most of my education on this comes from the Joe Rogan podcast. So
sure,
I think we're about on par. So this seems like a completely different angle to attack the problem, and that you would be going into like this, I don't know, hallucinogenic, if that's the right phrase.
Sure.
But to kind of break away some of those walls and actually get to what is the actual problem. I mean, is that kind of the idea?
Absolutely. As you had mentioned, the SSRIs and SNRIs are indicated for depression, number one, and then anxiety is an additional labeled indication. We treat differently. Some are more stimulating than others, but the interesting effect of, especially why I'm drawn to MDMA, is because MDMA is not a true psychedelic. It does have some psychedelic components to it because it's structurally similar to something like mescaline, which is a psychedelic, but a chemical component of it as well is that it's somewhat similar to the amphetamines. So there is a stimulating effect. That's where, like you had mentioned, you alluded to a little bit of like the street drug. It has that amphetamine component where you're hyped, you're active, you're stimulated. But the unique thing about MDMA is it's considered an empathogen, or another word is entactogen, and that verbiage insinuates that there is an empathetic nature to it. It allows the amygdala, it works on the amygdala, and it allows you to look at your past experiences with more empathy. So not only do you process the decisions that you've made from a previous decision with more empathy, but you also look at those, especially within combat, that you were potentially defending, or the perpetrators or anyone with a more empathetic nature. And so it allows you to maybe reprocess a memory that you've had that was very triggering, but reprocess it with a lot more sympathy and empathy. And then there's a really vital component to this therapy, which is called integration. So you have these pretty profound experiences with the medication, but then how do you integrate that into your daily life? How do you reprocess those memories and also integrate it into your daily life? And that is a very pivotal part of this therapy. I do want to also make sure that I clarify here too. So they did a very, very extenuous studies. And when I say they, I can't really speak, like you said on this disclaimer, but the Multidisciplinary Association of Psychedelic Studies is who is doing the crowdsourcing and who is funding these studies. And so all of the studies have been completed at this point. They've completed phase 3 clinical trials, and MAPS did a really good data analysis to say, well, how much MDMA is required to get benefit. And they were able to narrow it down to 75 to 125 milligrams as an ideal strength of MDMA in order to provide just enough mystical experience to have an effect without causing like a true trip. So it's really interesting that there is an objective scale called the Mystical Experience Questionnaire that allows them to gauge how much of a mystical experience is someone really having. And they actually found that the higher the mystical experience did not necessarily correlate with the true benefit with the PTSD response. So there was a threshold that they tried to maintain this certain threshold, but not necessarily have this, like you said, really wild kind of psychedelic experience.
So you're talking about just kind of reliving some of those events with more sympathy, more empathy of the situation. Is that, of the people who have done it, do they see it just in a more detached, more logical way? Or
interesting. I really applaud you for using that terminology, because it's actually, I would say it's the opposite of detached. I would say because it's sympathetic, it's very emotionally provoking in that it's empathetic. Like you have sympathy for yourself. I've noticed within my training, watching patients undergoing this therapy, that they had a lot more emotional connectedness. So MDMA works on oxytocin as well, and oxytocin is your binding hormone, and so you feel a lot more, I think, attached and sympathetic, and it allows you to maybe not even the detachment is actually probably the opposite. It allows you to process it with much more understanding and sympathy for yourself and for others.
Okay.
It's very healing in that respect.
Yeah. And to be honest, I'd actually really like to understand what that actually feels like, because they, as a service member, you have to do tough things, and through some of the outcome is PTSD, some of it is moral injury in itself, and you find yourself, at least myself, thinking logically about it. They came to fight, I came to fight. This is what happened, and
Right.
that's the way things work.
Absolutely.
If you wouldn't mind, I guess, unpacking what you're talking about, emotionally connecting to it, I guess, to a nug like me, like, how would you explain that a little bit different?
Sure. So, and I highly encourage anyone listening, all of this information as far as the randomized control trials are open source. So MAPS has wanted to make sure that this information gets out and is readily available. So all of the phase 2 studies, and especially the phase 3 studies that are being utilized to help get this approved, are available. So I'm not disclosing any major secrets here, but like the phase 2 studies, a lot of them are combat veterans from the OEF, OIF, and they were able to, with their permission, we were able to see some of these MDMA sessions, and they would have, some of the stirring moments or recollections that they had was even potentially the music that was heard on their deployments, some of the very culturally sensitive events that took place. They actually wanted to listen to some of these cultural, like, music that they heard, whether it was Muslim music or what have you, or the specific events, whether it was with young children or, again, like I said, the other side, there's both sides to that story, but, trying to understand, I've heard people say, well, I had a much different perspective that these people were protecting their family, or that, they were able to put themselves in their shoes a little bit. Though I know that it's very triggering, probably, some of those statements as well. And, but to be able to look at it from a whole different perspective and emotionally put yourself in someone else's shoe and have empathy for their upbringing, their understanding, and try to find this common ground and say, at least put some of that resentment potentially at rest. And it is interesting too. I want to make sure, I can't speak from my own experience with MDMA. So there are certain contraindications for the medication, and I actually have one of the contraindications. So I have to use that information very much as this is through my training, this is through how the medication works from a pathophysiology standpoint, and this is what we expect and we've seen through these clinical trials. But I definitely can't speak from personal experience because of, it's everything, every medication, everything has a pro and a con, and I try to be very judicious with my own risk-taking behavior.
Yeah, absolutely. I've never done it, but that's just because I'm a nerd. So,
So one of the reasons it does,
okay.
Go ahead.
No, please.
I alluded to a little bit who is a good candidate for this and who's not, usually in the screening process, because it can raise blood pressure. It's not really too concerning. Like, the clinical relevance of the blood pressure increase is not concerning for most people. But if there's a history of high blood pressure, if there's a history of stroke, any cardiovascular condition, it is a lot more cautioned in the clinical trials, and this is how we believe it might be used when it's FDA approved and much more widespread as well. But blood pressure monitoring is recommended throughout the process, as well as making sure electrolytes are in normal range. So offering plenty of water, offering plenty of Gatorade is a nice one, because of the changes in the electrolyte balance during the therapeutic process is important. So those things are definitely cautioned. So cardiovascular and seizure disorder are two things to be cautious of.
Okay. I mean, are there any other indicators of, like, this methodology or this technique is more than likely going to help this individual, or is it just a matter of, well, we tried this stuff, it didn't really do anything, so like, screw it, let's try this.
And it's really where I applaud MAPS and the individuals that are going through the clinical trials is that a lot of the individuals had an active diagnosis of post-traumatic stress or post-traumatic stress disorder for several years, 10. I think the median in the phase 2 trials, I believe, was like 15 to 20 years of PTSD, some of them. And often it was medication combined with therapy, and they were still treatment resistant. And it's indicated for moderate to severe PTSD. So, it's not that these individuals were, looking for the next new thing. It's that these individuals were definitely looking for help. And I really applaud MAPS and the study investigators as well, too, because suicidality, those individuals that were looking for help were not turned away due to active suicidality. And so they said, well, you need this. Let's give you the therapy. And now, of course, these patients were highly monitored. So frequent contact with the participants is part of the protocol. And they did not find an increased risk of suicidal behavior with the therapy. And I can talk to a little bit as well about the results of the
yes, please.
Okay. So this is what's really cool, and this is what really makes me want to advocate for this therapy within our population is they had, I believe the phase 2 study sites had at least 6 different sites that were actively investigating this. And these studies have been going on for several years. They found that in the individuals that were eligible for the study, they found that 67% of those individuals at 12 months after therapeutic intervention were fully in remission from PTSD. And so this is moderate to severe PTSD, but then after at least 2 to 3 treatment sessions and 12-month follow-up, at least the statistics were that 67% were no longer diagnosed with PTSD.
Yeah, that's incredible. That's incredible, right? Especially when you're considering, 22 veterans a day are committing suicide. Even if you can reduce it by 10%, like that's incredible. It's incredible.
Agreed. And they've had a number of participants that went through the clinical trials go to Congress, lobby Congress. I will say there's been several investigators that have gone to the Pentagon to try to get this actively enrolled within the active duty population. The active duty is actively looking to be a study site for MDMA. All that is in the works. I know at least 6 VAs had clinical sites for MDMA right now. So it's a matter of, I can't speak to the policy or the parameters of the VA either, but within the investigational role, the VA has brought it on as an investigational clinical trial. Now, once it becomes FDA approved, how that will roll out within the DoD and the VA, I think that's what hopefully most of our mind and energy is getting put towards. Like when this becomes available, which at first we were hoping it was 2023, now it's looking like 2024. Are we ready for it? And can we get this out as soon as possible so that we can get the treatment to the patients?
Yeah. Speaking about getting treatments to the patients or even just starting this trial to begin with. So, hallucinogens, as I believe, all of them were class 1
yes.
narcotics.
DEA.
And from the DEA. And so that states like there is no scientific use there. Like there is no good reason that anybody should be doing this. So we're going to put this under lock and key. Like how on earth did they ever even begin this process? Like somebody had to blink.
Well, it's so interesting, and this man is fascinating. Rick Doblin is the founder of MAPS, and he used his Harvard thesis to his thesis was how to get a psychedelic essentially approved through the FDA. So I think this was 20, 25 years ago where MAPS was first created to get this approved. And it was shortly after the DEA had made it a Schedule 1 controlled substance based on Nixon's war on drugs. And so once that became a controlled substance, I think a lot of people started saying, well, how do we get this available? Especially because they saw that it was so good in therapy that they knew that it was going to be a disadvantage for a lot of people that truly needed it for therapy. And so it's amazing how long it takes, but it just, goes to show maybe red tape. I can't speak to that a whole lot, but there's been a lot of passion, there's been a lot of work, and you really have to take your hats off to the individuals that have been behind this for 20 and 25 years. And there's several individuals that were providing it with medical licenses because they knew it was important, but they were risking their license to make sure that the data could be collected and that the individuals could get the treatment that was helpful for them.
Yeah. Obviously there's always, just about any study, you're going to have people that have success. You're mentioning, 70% of the patients who undergo this treatment, a year later, we're still in remission. Have there been any negative side effects or patients like this did not help him at all? In fact, now it made him worse.
Ooh, that's a great question. So if we had 67% that had full remission, I know that they did really stringent monitoring because as a phase 2 and phase 3 trials, you have to collect there was 2 different verbiages that I saw throughout the trials where it was like a sudden adverse effect, and some were categorized as like, the ones that they're really particular about is if there was an increase in suicidality. And that was not found to be the case. If anything, the placebo group did experience an increase, but the MDMA active control group the MDMA active group did not. So the things that we had to monitor for is like if blood pressure changes, if there was a large change in distress. So because this is an empathogen, because it's bringing up potentially negative past memories, there is close monitoring because we do know that you're going to have emotionally triggering events, and that's through integration you want to be followed up with. So this whole time, during even the active group, you have 2 therapists with you at the whole time. So this is why it's really, really, and I appreciate bringing this up. The verbiage now is so important that it's MDMA assisted therapy. So you'll hear assisted therapy everywhere. It's psychedelic assisted therapy. So we do know that the active drug has a effect, but we know that the effect is best seen within the therapy component as well. So if anyone did have an emotional change or increase in anxiety or increase in distress, they had therapists available. They had within the clinical trials, I believe there was always someone overnight. The first evening after session, there was always someone available overnight should there be anything that needed to be talked about or discussed. And I would have to pull out the phase 2 and phase 3 trials again, if I wanted to give you the specific quotes, but nothing of concern has been brought up. And so that's what's really cool. It was so effective that the FDA in 2017 gave it like a special protocol assessment saying that if phase 3 is just as effective, they are going to try to fast track the approval of the medication. So as long as there was no safety issues that came up in phase 3, the FDA was pretty much saying we're on board with the approval. We just want to make sure that everything lines up.
Yeah, absolutely. So essentially the idea is you've already screened the patients, they get their dose, and now you have at least one spirit guide available if things are not going well, and they essentially talk you through it. Like how long would a therapy session last?
Sure. The sessions are 8 hours, and there's 1 to 2 administrations of MDMA. The participant is able to request the second dosage. of MDMA. And I do want to make sure and clarify here too, within the clinical sessions, there is every single therapist that was providing this had training through MAPS. And so they went through the MAPS training. And so a lot of them have histories or have backgrounds as licensed clinical social workers or psychologists or psychiatrists. So they have training in how to help elicit even from the therapy response. There's no specific therapy that is necessary because there's something called inner healing intelligence that they want to rely on, as in like your body knows what needs to be processed. It will naturally come up with a medication on board, and the therapist there helped coach you and help you process it with empathy. But yes, the sessions are 8 hours. There's usually about a month between each session. And then you're welcome. The second session is essentially a repeat to build on. And then some participants were, didn't want to do a third session. They had enough effect, or some were offered a third session. But 3 sessions were the most that were provided within the clinical trials.
Okay. I mean, has anybody ever refused to do the second?
So, and that's a really good question. I would probably have to defer to those practitioners that were really involved with the randomized control trials. I'm very grateful that I was able to go through a therapy session myself. Hopefully, I believe that this is all open source at this point within the phase 2 and phase 3 trials. I would imagine that there was some, whether it was logistics, there was only 6 study sites. If these participants were having to travel, or if overnight stays weren't conducive anymore, I'm sure that there was probably some, and those would be accounted for within that data set. How many were screened as eligible? How many didn't go through with the protocol? And so all the data is also collected with what we call number needed to treat, and how many actually had the therapy versus how many did not. And that's where the data becomes so interesting too, because that is a clinically significant number, with having all those designations and every single person accounted for that was screened as eligible.
Perfect. How would somebody, like, they're by themselves, or their family members are concerned, or they just know that something is wrong and what I've been doing doesn't work? How would a person find a site? How would they get involved?
Thank you. MAPS, again, Multidisciplinary Association for Psychedelic Studies. So if you Google MAPS, and you can say MAPS studies, but there's a MAPS has a website, and they have an option for you to go in there and apply for their for studies. Now, with the phase 3 being complete, to my knowledge, I don't know if they're still actively enrolling. I know when I first looked into this therapy, like as to provide the therapy, this is like a year and a half ago, they were actively enrolling. And so that would be my first source, is to go directly to MAPS, who's done all the funding, go to their website and see if they are still taking participants. And I would put your information in there. There's several veteran groups that are using a lot of other therapies to help get assistance with treatment-resistant PTSD, as well as addiction. The interesting thing is MDMA is actually being studied now for other indications than PTSD alone. So they could also be enrolling for marital discord. So the partner relations is going to potentially be an indication because of the empathy, which is really unique. You're being able to look at your partner from a much more empathetic standpoint and have improvements in spousal relationships is wonderful. Addiction is another route that they are going. I don't know if they're going to go through a full FDA indication for those. It makes sense that they would if they're actively enrolling and studying that. But I encourage them to go to the website and look at all the different avenues that MAPS is using this therapy.
So do you think, as I understand, this is probably one of the first like hallucinogen type therapies. Do you think this is going to open up doors to other options?
Yeah, it's interesting because if you read into or you watch any like Netflix How to Change Your Mind, or if you read into Rick Doblin's philosophy about this, once this becomes FDA approved, all the options that will be available. So ketamine is currently available on the market. We do expect psilocybin to be available. I shouldn't say we, but there is an expectation that psilocybin is likely going to get approved through the FDA as well in similar time frame. So being really judicious and understanding which one may suit each individual better or best is going to be the next phase, I think. Okay, these are our options. Who would benefit from which intervention most?
Right.
I think that'll be the big one.
Yes. And also, just as people are looking, you're always going to find somebody that's willing to give you something to fix whatever the thing is you think you have. This is the only like approved route to do this. This is the only one that they've actually done studies on and collected data, not Steve-O in the trailer park that promises the same results.
Well, it's really interesting, and I appreciate you bringing that up because psilocybin is in randomized control trials, and I have not specifically delved into those control trials, but I will say a lot of those that underwent the training with me were very closely watching psilocybin as well. Ibogaine is being studied in clinical trials, albeit that is out of the country, but it is being researched. And ayahuasca is being researched. What I find, MDMA is really unique in that it's really truly the only empathogen that works in quite that same nature. Like you had mentioned, some of these are truly classical hallucinogens, and they will work kind of through this like ego dissolution, whereas MDMA is much more like I'm going to connect with my emotions, connect with other people's perspectives, and that's, that connectedness is what makes it so unique.
Okay. Is there anything else you would like us to know about the therapy or MDMA or trials?
Oh, there was something that popped into my head when you said it earlier. And it just went back out of my head, but I highly encourage you. All this is open source. So if you are interested in the data, if you're interested, it's all about patient selection and understanding if you're a good candidate. And it really becomes really empowering if you're able to go and look and have that data readily available to you. You don't have to speak to a practitioner. There's no stigma asking about these questions. I think, if anything, it's becoming very commonplace to ask about this. But if you Google MDMA trial, you'll see all the data. You'll see the patient characteristics. You'll see the years that they've tried, like EMDR, cognitive behavioral therapy, and so like the baseline demographics. It's just so fascinating to have that so readily available. The other big thing I want to say is, I really appreciate you having me on. I am by no means a frontier woman in this field. I am grateful to have been trained by the frontiers in this practice. I'm kind of grateful to be handed the torch, as in like it's been 25 years of real pioneer work, and I kind of just hope to be able to take this as now a very evolving picture with the FDA approval, and to be able to take it from there. That's my passion and my goal, and I just highly encourage anyone listening to be able to research and look into it and know that there are options coming. I don't want anyone to feel like, oh, we've exhausted everything. Even my role within pain management, I hear mental health come up so much, and I try to just encourage patients, just do some research, keep an open mindset, and sometimes it's just a matter of timing.
Yeah, absolutely. Well, thank you very much for coming on and educating me on this.
Thank you. I appreciate your time, and I appreciate the platform, and hopefully this becomes the real deal sooner than later for the right patients.
Absolutely.
Yep. Thank you, Dennis.
That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy is waiting there for you.